Um, for those of you who don't know me, I am Mary Willard. I'm the Operations Director for the National Association of Councils on Developmental Disabilities. And we are very excited today in order to have this partnership with the National Association of State Directors of Developmental Disabilities Services to share with all of you in our network information on the Link Center. So again, the Link Center is funded through the Administration on Community Living to improve access to mental health services for people with disabilities. Um, we at NACDD are really excited to bring this presentation to you because, as we all know, in this community, there are still many barriers that we have to overcome in order to ensure that this population of folks with developmental disabilities can receive mental health care in a meaningful way. So we are very grateful again to both of you for being here to present with us. For those of you who might need it, again, if you need to turn on your captions, you can go ahead and just hit the CC from the bottom of your bar. If you don't see it right away, you might want to click that dot, dot, dot or more and pull up a screen to look for captions there. And this material is going to be recorded, and our team at the National Association of Councils on Developmental Disabilities will be sending out the recording with the materials to all of you that have registered. And we hope that at the end of this series, you will fill out a survey that will pop up in your Zoom screen when you close this webinar out. That is a evaluation form for one of our projects called the Grassroots Project through HSRI that we are a part of and that we are holding this webinar in conjunction with. So I am very excited to turn over to Stacy Nonemacher. Darn it, I think I did it wrong. Sorry.
Okay.
In order to take over, if you could please repeat your name. It just totally blanked when I came
Oh,
up. Again, thank you all for coming, and I look forward to the conversation today.
thanks so much, Mary. Hi, everyone. I am Stacy Nonamaker, and with that last name, I usually answer to it all. But we are so very grateful to be here today. You'll be hearing mostly from Nancy Thaler, who is the project lead for the project and the content that we will be discussing today. I am Director across Systems Strategies. And as we said, we're just very excited to be with you today to be talking about a project that was funded by SAMHSA, HHS, and ACL through a grant, a project of national significance called the Link Center. Not sure how many of you have heard about the Link Center. Um, Nancy and I are both with NASDS, the National Association of State Directors of Developmental Disability Services. And NASDS is the lead partner for this grant. We do work closely with others, as you can see on your screen, NASHBID, NAD, NASHA, all the letters, and all people that have expertise and influence in our goal for the Link Center, which is we aim to increase mental health access for people with disabilities. So you can find out more about the Link Center if you haven't heard about us, if you haven't checked us out yet on our website. The website address is here on your screen as well as a QR code. And someone just dropped it in the chat as well. Thank you so very much. We engage in lots of activities through the Link Center that's beyond the project that we'll talk about today. And really, again, all with the goal of providing better support to people across the lifespan who have co-occurring conditions like intellectual developmental disabilities, brain injury, with a mental health. So what we always say about our website is um, to check us out often, and to get engaged. All right, I'm seeing that somebody is not seeing the, okay, so we're helping our friend out there in the chat. Wonderful. So today we're going to take the time that we have with you to share findings from our year plus analysis of state policies and practices around supporting children with complex behavioral health needs. We spoke to states, we interviewed states, we did focus groups with states, we did surveys with states. We also spoke to subject matter experts, talking to them about what their practices are, what their experiences are in supporting children who have complex behavioral health needs. We have a paper that's going to consolidate all of that information. Today's information is going to be an overview of that paper. We hope that that paper is coming out soon. Another reason for you to get connected to our website, because we will be putting the paper up there, and really will be a deep dive into the content that Nancy will be taking us through today. And really, by way of content, what we're going to be talking about are the things that we focus on. So, oftentimes in our systems, we will label people as complex or challenging. And so, we really wanted to dive into what does that mean? So, who are these kids? And how do we really define complexities? And what does that mean when they show up, right? We also talked a lot with states and subject matter experts around how do we support these kids. I myself, prior to coming to NASD's, was a clinical director in the state of Pennsylvania, and really thought a lot about what are those supports and services that people need, especially those who have co-occurring mental health conditions. And then not just what are those practices, what are those treatments, what are those interventions, but the next step, which is the third thing that we looked into, is what can we do? How can we structure ourselves to endorse and support those practices and interventions? And so today we'll leave you all with a call to action, if you will, which is, so what can DD councils do? What is your role? What can you all do? So that we can all collectively be on the same page, reading out of the same playbook, and support kids with complex behavioral needs better. So, what we'll leave you with today is a framework for all of that. So, how do we structure, and how can you all think about what your next steps are to better supporting kids with complex behavioral health needs once you understand who those kids are? And Nancy will spend some time really taking us through that. So, the framework that you'll hear throughout the time together today, and just to really set that up for you all and get you thinking about it, is we really have framed what we learned into three pillars. And the first one is these kids need to live in a place that is safe. These kids need treatment to heal, and these kids need opportunities to grow. And so now, without further ado, I'm going to turn it over to Nancy, and she'll take us through who are these children, how do we support them, all within that framework of creating a place that's safe, treatment to heal, and opportunities to grow. So, Nancy, I'll turn it over to you.
Great, thank you. And just testing, everybody can hear me okay? Great, good. Um, I am really happy to be doing this with the DD Councils. Shout out to Jill, who's on the webinar listening in, because she's the one who saw the benefits in working together and doing this. And we stand ready to help you do even more in this topic area. And I'm particularly pleased to be doing this with the DD councils because I think that you are a critical partner in all of this. So I've done a lot of things, but one of the things I've done is I was the state DD director in Pennsylvania for 10 years and then another 4 years more recently. And shout out to Lisa Tesler, who's on the webinar today. But I can't imagine advancing our systems without the DD councils. And I'm a big supporter of the DD councils and a defender of the DD councils. Um, in our state, the DD councils were acted in some ways as a foundation that experimented and proved what practices were promising so that the state agency then would adopt them and implement them statewide. So in our state, the DD Council invented family-driven services, it invented supported employment, it invented shared living, it set up through the grants exemplary programs that we then adopted in state government. So I am very happy to be here on the call with you today. And even in this project, one of the subject matter experts I tripped over and consulted with and involved was a project funded by the DD Council in Texas. So Beth Salve is going to be talking. So yeah, you got a big role here. Next slide. This project came about because state agencies, DD agencies, mental health agencies, Medicaid agencies, and child welfare agencies express frustration to their national associations and to the various federal agencies about these kids they don't know what to do with. Kids who are sitting in hotel rooms and boarding in ER rooms, and no providers will serve them. They're funded to go out of state. They're institutionalized. And it is those children, the kids who have problematic behavior at the extreme end that this project was about. So go ahead, keep clicking, Stacy. So what did states tell us in our interviews? That they were generally in their late teens, not always, generally in their late teens, male and big guys, reaching adult size. The behavior is pretty scary. It's frightening. It's dangerous. It's sometimes odd and weird and not understandable. Can't find anybody providers to serve them. And as I said, they're living in ER rooms and hotel rooms and CYF offices, going out of state at great amounts of money, often to places that just physically restrain them. Um, One of the things the state DD agencies told us was that when they have these teens or even young adults after 21, that they very, very often have been involved in the child welfare system, meaning there's a history of trauma here. And then lastly, I think there's one more click. Yep. Multiple foster placements. I myself have a 62-year-old son who, in his early childhood, was in 9 foster homes between the ages of 5 and 7. Um, and then failed adoptions. There's a high rate of failed adoptions, which is really traumatic. Lost your first family, lost your second family. And then, as I said, multiple institutional placements. So this is a very sad profile. And one of the things I want to say about these kids to you, the DD councils, is this is the last group of throwaway people. So our history in the system has been we do good by some people, but not those people because we can't figure it out, or they're so severely impaired we can't help them. This is the last group. And the reason it's the last group is because we kind of figured out pretty much how to help everybody but these kids. And until recently, last decade, we could institutionalize them. They were long-term stays, ended up in state hospitals. And the litigation that the Department of Justice has pushed in a number of your states and the Administration for Community for Children and Families, which is putting pressure on child welfare agencies not to institutionalize, has exposed these. They're not new children. They were there all along, but they are now exposed, and we can't walk away from them. And we need very much for the DD councils to step in their advocacy role and their support role in developing programs to be the allies of these kids. Next picture. So the actual data from the states in the survey to the states gave us real data. I already told you about gender, but here is age. These are predominantly teenagers. They're bigger kids. Yes, we see 0 to 5, but they are predominantly that 13 to 15, maybe 12 to 17, I'm sorry, age range. And I'm going to talk later about why that might be. Dysregulated behavior. The states did not use that term. We label this dysregulated behavior, and we'll talk more about that. But aggression is the big one, hurting other people, disrupting the environment, self-harm, including suicide ideation, a lot of property destruction, knocking down things, smashing things, busting through things, inappropriate sexual behavior, and elopement. And these items, and I don't know why they're 1 through 4 instead of 1 through 6, but at any rate, they are. I just noticed that. They are the behaviors in the order and the frequency with which the states reported. So mostly physical aggression, next disrupting situations, etc. Developmental conditions that were most common, autism, no matter what you do in this topic area, autism's at the top. You cannot help these kids if you do not understand the spectrum. Um, then IDD, then ADHD, surprisingly so. ADHD was very high up, and then complex medical conditions and fetal alcohol syndrome, also surprising because it's so underdiagnosed, and learning disability. So these are the developmental conditions that states in their data reported. And of course, the story here is only as good as the data is, and it's not comprehensive, but a reasonable sample. Mental health conditions, oppositional defiance disorder was the most commonly reported one. Trauma, PTSD, anxiety is right up there at the top. And if you understand autism, and I often say anxiety is along for the ride. Conduct disorder, depression. So those are the mental health conditions. And then physical health conditions. And with great clarity, these are the three big ones: diabetes, seizure disorder, which is not surprising given that seizures occur in the prefrontal lobe, and that's where so much of this dysregulation is, and asthma. Next slide. Um, and these are just descriptors. These are the words, right? Outburst, screaming, aggression, destroying property, firing, fire setting. Sleep disturbance is a common one. Running away, feces smearing, enuresis had a range of problems in and of itself because of hygiene. Uh, a, a description of discrete examples of what kind of sexually related acting out behavior we're talking about, and then a range of self-harm. So this is a description of the behaviors. Next slide. So we know who these children are. What all these children, if we were to say, let's define the problem in the way Einstein said, if I had it, if the Earth was threatened and I had 1 hour to figure out 1 hour to save the Earth, I would use the first 50, 90 minutes defining what the problem was. And the message there is, if you define the problem accurately, you've got a better chance of finding a solution. So here, the problem the states don't label, but what is that these children, no matter what the diagnosis, no matter what the condition, what they're presenting to the state is dysregulated behavior. They are emotionally dysregulated. They cannot control their own behavior. And this is not an uncommon thing. And on this picture, I include adults because this happens in adulthood. We call it an anger management problem. It's the same thing. It's dysregulation. It's what is demonstrated when a person is overwhelmed by sensations, emotions, thoughts, feelings, and they act on them without being able to control what they're doing. Next slide. Okay, what is dysregulated behavior? It is intense and it's maladaptive. So when the states are describing this is not nice behavior, it's maladaptive behavior that is disproportionate to whatever the real situation is. They are not managing emotions. The behavior is an indication that they're not managing the emotions that are inside, and that there's harm, there's problems. Next slide. What it looks like. So I'm getting a little more clinical and a little more based in research, and what you'll see NIH or CDC, the terms they use to describe this: impulsive and aggressive actions, or you'll emotional outbursts, self-destruction, interpersonal conflicts, and withdrawal. That box is a really good listing of the categories of this maladaptive behavior that is exhibited. On the right are the synonyms you'll see, other ways of describing emotional dysregulation, behavioral dysregulation, affect dysregulation, impulse control, emotional instability, act. These are all synonyms for behavior that is an indication of the person's dysregulation. Next slide. So, one of the things I often say at the beginning of this talk is buckle your seatbelt. We pack a lot of information in here. These children are complex. The description of who they are is complex, as is the solution. Very doable, but still there's complexity here. So I'm just sort of alert that there's a lot of information packed in this hour. Okay, dysregulation is not the diagnosis, it's the symptom. And the question is, a symptom of what? What is it I need to treat? And it turns out that there are multiple causes for dysregulated behavior. One is a neurological condition or a neurodevelopmental disability. So with autism, with ADHD, with IDD, with Fragile X, there are a million neurological developmental disability descriptions. Accompanying them is difficulty managing emotions and behavior. It's part of the developmental disability very often. A second driver is trauma or neglect. Neglect is trauma. It's a different way of talking about trauma. But trauma and neglect also do things to the brain that make it difficult for people to control their emotions. A third, certain mental health conditions make it difficult to control one's emotions and behavior. Bipolar disorder, depression, anxiety, etc. There's a fourth I should have inserted here and didn't, and that is certain physical conditions. And what I mean by that is physical conditions that cause pain or disruption can also be the source of dysregulated behavior. So we need to add that. And lastly, adolescence. And I do want to talk about adolescence in itself as a cause of dysregulated behavior. So, in other words, if you're asking why somebody's dysregulated, there can be different reasons, and most frequently, more than one reason, more than one. But knowing what the cause is important so you know what to do. Next slide. You're the councils for developmental disabilities, and historically we've been thinking in terms of intellectual disability. You know that the statute defines developmental disability in a certain way with certain conditions. That's one definition of developmental disability. Neurodevelopmental disabilities is becoming a much more broadly adopted term in research and in the medical profession. You'll see pediatricians publishing this, and what does it mean? It's not well defined yet. It's not in the DSM. If you look at the National Institute of Health or the CDC, they'll typically define neurodevelopmental conditions about 4 or 5 kinds. It's always autism, it's always DHD, most often it's intellectual disabilities, maybe the FAS, but we're using this in a broad sense to apply to a group, any condition, group of conditions that affect brain development, and that brain development impact impairs cognition, behavior, motor abilities. So there are lots of different conditions that happen in childhood, either birth or after, that changes how the brain is functioning, and it's not, as we say, neurotypical. It's not within the midline of how most kids behave. And it's fetal alcohol syndrome, autism. I mean, you have the list in front of you. So we're talking about neurodevelopmental disabilities, people whose kids, adults later, whose brains are altered because of conditions or experiences or their history that they have. Next slide. So, a couple things about neurodevelopmental conditions that are important. And we did a webinar earlier this week for medical people and mental health people. The thing about the developmental disabilities is that there are functional limitations. And there are two problems with that, although that's not clear on this slide. The first problem, yes, it causes stress, and I'll get to that. But the functional limitations, sometimes we use the word masking. So when physicians or clinicians meet folks who have neurodevelopmental disabilities, they will ascribe whatever they see to the neurodevelopmental disability, meaning it's just a characteristic, nothing that can be treated. So if I see anxiety in someone with autism, it's because of their autism. And I don't look at the anxiety as a separate condition. So it interferes with accurate diagnosis also because these folks can't talk often. And if they do talk, they are not in touch enough with their bodies and what's going on. They're dysregulated. So they can't communicate to people who are doing diagnoses exactly what's going on. And the second problem is that these functional limitations for the person themselves causes stress. I mean, we know that, for instance, adults who have strokes and develop aphasia and can't speak get very angry and sometimes act out. The inability to function, to communicate, to control what's happening to you, to understand events itself causes stress, and I would say trauma, stress-related trauma, which causes dysregulation. So this is a layered experience people have. Next slide. So this slide has a list of neurodevelopmental disabilities, and in red are the words that indicate problems with self-regulation. So all of these have impulsivity, emotional control, anger management, property destruction. I mean, any list of things that say when people have this diagnosis, they're probably having a hard time because of that diagnosis controlling what they do. And so this would suggest that we stop thinking about behavior as intentional, as manipulative, as intending to get an outcome, and instead view behavior, dysregulated behavior, as communication, as an indication of an underlying problem, and they need help. Next slide. What it's like to be neurodivergent. You guys, the DD councils are incredible at involving self-advocates. So I don't think I need to do this. These are the words of Barb Moran, who's out in Kansas, and she just writes in her book, as do a number of other people, about what it feels like inside. And what she's saying here, when she's a little girl, she used to keep pulling her under, like this is habit, compulsive habit, pulling her underwear up, pulling her underwear up. And she said it was a horrible sensation and it kept getting worse and it was miserable. And her parents were nagging her to tell her to stop because it was a ridiculous behavior. And the more they nagged her, the more the pressure went up. The more the pressure went up, the worse she felt, the more she was wanted to pull up her underwear. And she couldn't stop. And she says that's when she realized something was really wrong. Barbara ended up raised by loving parents whom she loved the rest of her life and a sister that she's very close to. She went to the Menninger Clinic and where she was sexually assaulted, which is something she's dealt with in her adult life. Because when she was a little girl, she's my age, so when she was a little girl, nobody understood the dysregulated behavior. Next slide. What I said earlier about you got to know autism to understand this population. And the thing about autism is it affects a lot of dimensions in life. Sensory integration, movement, proprioceptor sense, the ability to communicate, all of these things. And whether or not people with neurodevelopmental disabilities even have the diagnosis of autism, they may have those symptoms, for instance, inability to process what they hear or inability to tolerate touch. This is by people on the spectrum who are describing in this lovely cartoon what the symptoms are of what's often referred to as meltdowns or burnout and what the signs are and what people could do to help. I'm not going to walk through it in detail, but it reframes what autism is. Autism is an experience I'm having in a lot of domains in life, and you can help me modulate those experiences so I can calm down. Next slide. So, second category that causes dysregulated behavior is trauma and neglect. Next slide. To understand why it is trauma causes dysregulated behavior, you got to know about the brain. The decade of the brain was in the 1990s. We know an enormous amount about the brain, much more than we did before. And we like to say where we're coming from and what our recommendations are neuroscience based. You got to know where in the brain emotions are, when that part of the brain comes online with a child, and then what causes emotional dysregulation. Next slide. This is a lot of you know about brain development and trauma, so this is like a refresher, maybe. So, what we know is that what goes on in the brain, the core function of the brain is neurons that communicate with each other, that neurotransmitters, hormones, chemicals are sent from one cell to another cell, building a neural pathway, and that's where competencies and skills are developed. So if you look at one neuron, the sending cell, to the receiving cells, think about something like dunking a basketball. The reason people get better at doing that is because they do it over and over and over again. And that axion connecting those two neurons with neurotransmitters gets stronger and stronger and stronger because it's repeated until people think they have muscle memory. And they don't have muscle memory. That's not why they're doing it. They're doing it better because that neural pathway has been strengthened and built. And the phrase neuroscientists use is neurons that fire together, wire together. So, repeated performance of something that's positive is going to create a firmer neural pathway for that positive event activity. Conversely, if it's negative, it will be negative. Next slide. So stages of brain development, you can just click them all on at one time, Stacy. So in early childhood, I'm oversimplifying brain development horribly, but it makes the point that in early childhood, basic sensory processing is going on. Big one is language acquisition. If you don't, if an infant, if someone in this age group, a child in this age group, does not hear language, they're not going to develop good speech. If at that stage people talk to them in two different languages, they will effortlessly learn two languages from 0 to 5. Not so much 11 to 12. 11 to 12, learning the second language is going to be a big lift. But from 0 to 5, those neural pathways are just being built, as are the neural pathways for emotional regulation. So if you're 0 to 5 and you are, and I'm going to get to how emotional regulations happen, if that brain development at that point in your life is disrupted or not allowed to develop, attaching relationships. This is when baby and mommy are coo-cooing to each other, and the baby is frightened and disrupted and scared, and mom soothes that baby and looks at that baby and smiles at that baby. It is that dialectic back and forth where the child begins to trust an adult, see themselves in the adult as a worthy human being, and develop trusting relationships. But if that mom is an abuser, that ability to develop an attachment isn't going to happen. And in fact, that child ends up having what is often called reaction attachment disorder, the inability to develop attachments. Middle age, around age 6, is when the prefrontal lobe begins to develop. And we begin to see planning and making decisions. I want to make decisions for myself, even though I'm not competent. But that prefrontal cortex in the front of the brain starts around age 6, starting to mature, but it doesn't really happen and isn't finalized until the 20s and 30s for boys, 20s for girls, 30s for boys. And then finally, in adolescence, what's going on in adolescence? Adolescence is when the hormones turn on. We become highly social, risk takers, externally oriented, forget mom and dad and home. I'm out in the world. I want a lot of friends. I'm on social media. and risk taking happens. And risk taking is, from an evolutionary point of view, quite functional. We need young men to go to war, to oversimplify it. So risk taking, trying things new, this is a good feature, but it can also be a problematic feature. Next slide. So in the brain, lots of moving parts in the brain. Three big ones when we talk about trauma. One is the amygdala, that little almond-shaped thing in the middle of the brain where we sense, feel emotions and sense danger. Another important part is the hippocampus, which is where we store memory, where we learn and store memory. And third is that prefrontal lobe I was talking about, which is the executive function, the manager of the brain. So these three parts of the brain are critical in life, in protecting ourselves and in controlling ourselves. Next slide. So what happens when bad things happen? When bad things happen, that amygdala, that little almond thing in our brain, is on the alert and starts giving notice to the rest of the body. I think I can't remember what body part, to start producing cortisol. Cortisol is the hormone that goes through our body, that gets our hearts beating rapidly, shuts down our digestion, dilates our pupils because we're ready for the tiger. We're ready for the attack. We're on alert. So those parts of our being ramp up for the fight, and other parts of our body get shut down because they will get in the way. So that's not when you want your stomach digesting food. You're just going to go off the fumes and shut that part down. The hippocampus, and this is really remarkable, the hippocampus was really close to the amygdala. It literally shrinks. It gets smaller and does not store memory because you don't want to be remembering the trauma, which is why so many people can't describe the automobile accident or they can't remember what happened to them because the brain matter in that part of the brain just went offline. And the prefrontal cortex goes offline. The response to a threat is instinctive, not planful. So that part goes offline. Next slide. So what trauma is doing, it's impairing the person's ability to self-regulate because the body and the person is responding instinctively. So the amygdala, it's the adrenal glands that push out cortisol, increase that breathing and heart rate and digestion, and closes down the senses because you are so focused. Um, it is very hard. Anybody who's ever been scared to death, no, you don't immediately go back to a calm state. The body's pumping everything out. The heart's racing, anxiety's up. You're in a hyperaroused state. You're in the fight, flight, freeze mode, and it impairs the ability to self-regulate. Now, remember, going back, I said that people with neurodevelopmental disabilities who on a daily basis don't know what, yeah, somebody put up body keeps the score. Absolutely, everybody read the book 5 times. It's the Bible of understanding this. And so your people are in this mode. And if you've got a neurodevelopmental disability and you can never understand what people are saying, you're always in the fight or flight mode. You can't figure it out. Next slide. This is I think, a nice takeaway to understand what the sympathetic nervous system does and what the parasympathetic nervous system does. And what we want to do is build up in these kids and adults the functions of the parasympathetic nervous system. We want their heart to slow down and get in a slow rhythm. We want their breathing to be full and slow. We want their pupils to stop being dilated. We want their digestion to work. We need blood flow from the gut to the brain to work. We need their parasympathetic nervous system to calm down and to kick in gear and counter what's going on in their sympathetic nervous system, heart racing, breathing, hormones going. And as you can imagine, if you're in the fight or flight mode, locked in it, you're not thinking. You're not thinking, the hippocampus is not thinking, you're not managing your own behaviors. Next slide. Um, so when trauma happens in the brain stem, and this is a depiction of by year, same thing. The brain stem is developing in the first year, it's the basic functions. In that 2 to 3 years is when emotions are developing, when the hippocampus is developing, and 3 to 5 is when we begin to start to learn to self-regulate, right? So if you've raised kids, that's about the time when you expect children to be able to calm themselves down. Next slide. This is it's a great visual of hypervigilance. We don't see the monster, but they see the monster. It's a survival mechanism. If you've ever been assaulted, when you go outside, you're always scanning the environment to see if you're assaulted. You sense threat even when one's not there, and your amygdala will rage at the thought or the smell or the sound of something that is a familiar threat. And so our kids, this is how they where they are. Next slide. We all start this way. I love this picture. Pretty newborn. We all start dysregulated. Every wet diaper, every hunger pain is life and death, and we scream bloody murder until somebody comes and helps us. Next slide. And you can go through all of them, Stacy, pull them all up. Um, it is through repeated, I just have to, through repeated secure interactions that babies transition from needing external help to developing self-soothing skills. And one of the first ones you see is thumb sucking for self-regulation. So, what are the key aspects? And so many of our people don't get this because their infancy and toddlerhood are either disrupted by abuse and neglect and problems. As we know, the number of coming out of child welfare of kids who have trauma is really, really big. But even if that doesn't happen, even if you are in a family, a loving family, they don't know what to do. They're afraid. They got the new baby. The doctors don't really tell them what to do. And going forward, some of the basic skills families have for neurotypical babies don't get executed for neurotypical babies. So here we go. It's co-regulation, a consistent, responsive caregiving that helps them learn that their emotions, that these terrible emotions will pass, and then they build trust. Having a secure attachment, the caregiver that you can count on. I know mommy's going to come when I cry. I don't have any doubt about them. And over a couple of weeks, I'll have confidence that she's going to come. So I won't scream bloody murder as soon as my diaper is wet. I'll show discomfort. But if she doesn't come, I'll scream. Brain development happens because of these social interactions, this face-to-face reciprocal social play. The brain is built, the prefrontal cortex is building because of all of that. They're getting cues. When the caregiver notices when a baby is tired or stimulated, their response to that, there's a concept called mirroring emotions. There are cells in the brain called mirror cells that will copy what the other person, if the other person's smiling, will smile because we're mirroring them. And then all the self-soothing skills, physical contact, the sucking, the pacifier, the thumb, the consistency of daily routines, the predictability of that. All of this calms the baby. Next slide. But what if the child is abused and neglected? What if there is no consistent care and feeding? There is no soothing or cuddling. And this is a very, very famous slide. If you go online and like brain problems with adoption, these slides all come up. They're from the research in not Bulgaria, one of the Eastern European countries, at Budapest, after the wall fell, and there were huge orphanages because, for a lot of reasons, political reasons, and they did brain scans on children and compared the children who had been suffered extreme neglect from children who are normal. And it is astonishing. The brain shrinks, which means all the functions that come out of the brain are lessened, including the ability to manage emotions. Click on the slide. Neurocircuits are disrupted, the brain shrinks. There are problems with memory and learning and behavior. It also relates to chronic disease. And remember when I showed you the early slide about what these complex kids have, how often diabetes came up and asthma? Um, and then the children develop coping behaviors that make sense in their environment and are completely adapted, but later in life get identified as pathology. Reaction attachment disorder is a common one. If I'm abused by adults, I'm going to learn you can't trust adults and don't attach to them. Don't put yourself in that risk. That's very functional adaptive and it's a survival technique. But later in life, when I'm adopted by a family and I'm pushing them away, I get the label reaction attachment disorder because now that doesn't match the environment I'm in. I should be able to trust these adopted adults because they love me, but I don't know that. My body doesn't know that. Next slide. And I want to say one thing. This is one slide that could be a whole seminar in of itself. One of the learnings from this project was the discovery of complex trauma, the term complex trauma, often called developmental trauma. And what this slide shows you is that the consequence of trauma that occurs in childhood is significantly different than trauma that occurs in adulthood. And the reason is adults who've had typical child brain development without abuse and neglect in their history have a healthy, functioning, developing brain that when they experience trauma, they can go back to. But when children are abused and neglected and traumatized while their brain is developing, it changes how their brain develops and gives them pathology with nothing to go back to. So, as I said, these coping behaviors get defined as pathology, intermittent explosive disorder, RAD, oppositional defiant, conductive disorder, person. All these are descriptions of behavior that are maladaptive in a healthy environment, but really were adaptive where they came from. Next slide. Um, I want to make the pitch to you guys in the DD councils. You don't typically get involved in child welfare, but that's where the kids are. This data is about the degree to which children in child welfare have developmental disabilities or neurodevelopmental disabilities. So the research is very dependent on the data available. It's not great data. Often the kids aren't screened, disabilities not recognized. AFGAR's data and Medicaid payments data, it doesn't necessarily identify the disability. And even though that's true, the researchers that have done this work say at least 30%, up to 45%, depending on whose research it is, they can document with bad data have a disability. But recently, the Administration on Child and Families published what I've been reading in all the literature that it's probably 80%. And so the higher you go up, the next thing says 72% of youth in the transitional age. The data that's available, the bad data, inadequate data, shows that by the time you get up into transition age, it's 52%. By the time you get up into 17, the transition group that's really going, it's 60%. And these are the kids who don't get adopted, who have rotate through foster homes. Um, but they've got disabilities. And then on the other side, why is this? Well, kids with disabilities are far more likely to be 3 to 4 times more likely to be abused than typical kids. They're far more likely to be in institutions. They're far more likely to have their adoptions. So these are our kids. They need allies. And I will tell you, there is no advocacy for these kids, not at the state level and not at the national level. The words complex behavior just gets assigned, and everybody assumes it's a mental health problem. It's not a mental health problem. It's a neurodevelopmental disability problem with mental health components and physical health components. Next slide. Adolescence. I don't have to tell you what adolescence is. You know what it is. You'd like to put every adolescent into a box someplace and live through it. Next slide. But why is this? Um, because, click, signs of a fully developed cortex is that we have consistent emotional regulation, thoughtful decision making, impulse control, the abstract reasoning is in place. That's a fully developed prefrontal cortex that most of us probably all have. What are the signs of an undeveloped prefrontal cortex? Impulsivity, poor judgment, reward seeking, emotional dysregulation, adolescence. Next slide. This is what makes them so vulnerable to social media. Adolescents are not wired to self-regulate. Their emotions and behavior are regulated by the prefrontal cortex, where executive functions happening. And it's the last thing, keep clicking, Stacey. It's the last thing to come online in childhood development. And here's the slide. There are lots of them around. It shows that the frontal part of the brain, the prefrontal cortex, where all that sophisticated plan, analyze, make good decisions happens, does not come online until late adolescence. And the amazing thing is that for girls, it's not fully developed until about age 25, and for boys, not until about age 30. So we're asking adolescents, and that, by the way, is why the states report most of the complex kids are boys in teenage years because they're teenagers. They always were dysregulated, but now they're teenagers and they're big, and now it's a problem that gets attention, but could have had attention earlier. So what do we do? This is gonna be fast. So Stacy, get your finger ready. And so what we're suggesting is that we need a new service paradigm. That the service paradigms we're using, which is the social model, which is a really good paradigm that enforces people's rights, assures they has opportunities, that there's inclusion, that there's self-determination. That social model is very good and very important, but it's not enough for kids who are and adults who are dysregulated. They need more. They need a service paradigm that is both trauma informed and aligned with neuroscience. We need to flesh out our old service paradigms. Next slide. And as Stacy said at the beginning of it, there are a million things in here. We organize them in three tranches so people can remember them. A place that's safe, treatment to heal, and opportunities to grow. Next slide. So next slide. What do the kids need? What do, Go back to yes, they need to calm down. They need help getting their nervous system calmed down. They need treatment for their trauma. They need attention for their developmental disabilities needs. And they're still kids. They need a chance to grow and develop. That's what the children, and I would suggest to you, adults need. Next slide. We're gonna go through each of the place that is safe. Next slide. This is a complicated tranche, a place that is safe, because it's packed with a lot of factors. So first, a safe place is how the person sees where they are and who they're with and what environment they're in. It's defined by the person. What feels safe for you is not the same of what feels safe for me. And safety is both physical, psychological, emotional, predictability, rhythms and routines have a lot to do with it. And cultural safety. Is it familiar to me? Do you recognize my culture? So there are a lot of aspects to the place and environment the child is in being safe. Next slide. But the most important one in this place that is safe is, oh, I'm sorry, let me sort of walk through this. So what makes that environment feel safe? It is structure and routines. Things is breakfast the same time every day. Can I count on dinner when dinner's supposed to be provided? What happens on the weekends? That predictability eliminates, reduces anxiety for all of us. And we all learned this through COVID. The more predictable and structured our life, the more our brain calms down because doesn't have to invent something every minute of the day. Stuff that's fun, some empowerment, opportunities for me to make choices, even if they're really, really simple. I throw pets in all the time because I think all pets are support pets. Otherwise, we wouldn't be spending so much money on them at the vets. They give us unconditional love, motivation. They get us outside. We're responsible for them. Thanks, Dana. These kids, this environment has to have stuff happens outside where they live, things to do outside, see other kids. And also in this environment is health and mental health practices that are healthy. Things like diet, things like hygiene, things like sort of walking every day or moving every day outside. So that if you're responsible for creating that environment, it's a lot of things. Next slide. But most importantly, within that environment and place are the relationships. And I quote here from one of the researchers at the University of Minnesota, the most important protective factor in building resiliency is the presence of at least one consistent supportive relationships with an adult. And when you hear people who have successfully recovered their childhood, they will tell you it was my grandma, it was Aunt Millie, it was this teacher in school. There are a million stories, but they all are based on a relationship with somebody who I could have confidence really loved me. And a lot of our kids don't have that. And if there is somebody, our system interferes with their relationship by making contact contingent on good behavior, by not facilitating phone calls and travel expenses, and not doing everything possible to keep them connected, texting, calling on the phone, all of that. If that is the only thing we do, we will have put a stake in the ground in recovery. But those relationships all need support. And the next thing I want to do and under relationships is talk about direct care staff and family members. They are the therapists, the mental health therapists, credentialed, certified, do a great job assessing, diagnosing, and suggesting interventions. But what happens when the meltdown occurs is what's important. What happens when I wake up in the morning and how people approach me matters. That the therapy is delivered through the interactions between caregivers and the person eating together, I mean, how intimate can you get helping me take a bath, right? Helping with homework, little crises, guiding me in relationships. That's where the therapy happens. And so treating direct care staff or family members, but particularly direct care staff, is as though they are just personal care attendants, is a mistake. Next slide. I'm going to put a pitch in here. Go Google gut health, brain gut connection if you haven't already, both for yourself, for your family, and for these kids. The brain and brain and the gut are connected. 85% of the serotonin that's we need in our brain, the good feeling hormone, is actually produced in the stomach, but it doesn't get produced if the stomach is full of donuts and McDonald's hamburgers. That does not create a healthy biome that creates a healthy brain connection. And so all these good habits that if you pay attention on the web for good brain health, you'll see all of these things. It is your diet, it is routines, it is exercise, oxygen, being outdoors, how well you sleep, and relationships. It's the formula for good mental health. And that's what the environment should be. Next slide. Social engagement, I think I've sort of beat this to death, but social engagement
One
is,
second, we've lost the PowerPoint.
you have. I see it on the screen.
Interesting
I see it.
line.
Does
I
everybody
see
see
it.
it?
See it too.
I
Hey,
see
please
it.
set a safe. Is that the slide that you're on?
Interesting. Cancel that.
Okay. Okay, we'll do. Next slide. I just want to say about this is the physical space, the physical location. We have places where kids live at home with their family, sometimes kin care and foster care, sometimes an adopted family, or sometimes life sharing with the disability field calls. All those places are based on a relationship. We send children there, or children are there because of who is there and the family context they'll be part of, which really sets the stage for all these good practices I'm talking about. Or kids go in facilities, group homes, or congregate care. Right from the start, being there is about being in a bed. It's not about with who you're with. It's not about that. And who you're with changes every 8 hours. And so that very structure begins to undermine the ability to create a safe place. But it's possible. It's not impossible, but there are really unique challenges that require directors and managers of facilities to be extremely purposeful about what goes on in those facilities to assure all those things that I said are part of a safe place are there. Next slide. Sorry about the rapid segues. Just a slide about plan for crises and setbacks. Recovery is not linear. Recovery, just like in drug and alcohol addiction, you go forward, you take a step back, you go forward, you take a step back, but in that process, you are strengthened. So everybody who's in caregiving needs to know bad stuff's going to happen, even though you're doing a really good job. Just hang in, help the person get through it, and get to the next step. And at most do no harm. Let's get rid of seclusion and let's get rid of restraint unless we have to save somebody's life. Let's get rid of using drugs to punish people and just get them to go to sleep and shut down. And let's stop making things they love rewards to avoid bad stuff. Every time you say to somebody, you can go home if you're good, or you can have this, or you're good if you have to earn, it's trauma, trauma, trauma. I mean, imagine somebody doing that to you. So avoid harm. And if harm happens, or if you find yourself having to restrain, get into the practice of debriefing and making what do you do better so it doesn't happen again. To get past it happen, let's move on. And if at all possible, do not call police or emergency services. And a lot of states are developing 988 crisis intervention models that NASD's and everybody's part of building up. So I think some of the mobile crisis stuff is now very, very positive. If you call the police, you're just going to traumatize people. Build in those emergency responses. Next slide. I'm really conscious about the time here. A paradigm treatment to heal. This is equally as significant and meaty as a place that is safe. Next slide. So I'm going to talk about physical health very briefly. Next slide. When we threw the medical model out, we threw the baby out with the bathwater, and we forgot people are physical beings and have physical health issues. So remember, these are folks who have trouble communicating. They're not in touch with their bodies. They have pain. They don't even know where the pain is. And so always assessing at a minimum for conditions that could cause pain or discomfort is important. Seizure disorders, asthma, terrifying. Asthma is terrifying. Diabetes, toothaches. How often people are acting out because they have toothaches, headaches, sinus pain. The rest of the world is like taking sinus medication, out the kazoo. And do we ever ask people have sinus menstrual cramps, right? Or allergies that they also cause discomfort. Gluten allergies are deadly. Immediately test people for gluten if they have behavioral issues to find out, or other food allergies to see if there's something causing pain and discomfort for them. So physical health is a huge component. And now mental health. Next slide. So when we say these kids have mental health problems, we're going to send them to the mental health agency and refer them. This is the menu. The menu is dialectical behavior training, CBT, a DBT, cognitive behavior training, CBT, individual counseling, or group counseling. That's kind of it. All of those require communication and an exchange and thinking. So they are all valid. They are all really good evidence-based practices, and they sometimes work with folks with neurodevelopmental disabilities. But we're proposing here a much broader menu of options. Next slide. So the first is to understand in the DD world, we talk about habilitation. And I was in my home state recently, and I did a presentation for the Community Capacity Building Institute for children's programs for kids with complex needs. And while I was doing it, the organizer of the event stood up and said, "Remember, habilitation is not treatment." Wrong. While it might not be certified clinician-driven treatment, habilitation is the place that is safe. Habilitation is how we support relationships and social connections and build in daily routines and opportunities for exercise and games and good diet, having a pet. That's what habilitation is. It's the place that is safe and it can incorporate all these practices that set the stage for recovery. Next slide. This is the second big one, and whoever put up Bessel van der Kolk's book, Body Keeps the Score, as I said, read the book 5 times. These are all treatments that don't require people to talk and tell you what happened to them. So neurobiofeedback and neuroentrainment, cutting edge, not widely known, but just Google neurofeedback and your zip code, and you'll find a whole bunch of people who are practicing. It's true in my tiny little rural county in Pennsylvania. These are ways of, we now can see where in the brain there is under or overfiring, and we can do training technology interventions that help those parts of the brain calm down. EMDR, evidence-based, the military uses it, insurance pays for it. Almost nobody does it with our folks. It's bilateral stimulation. If you're working autism, you'll know about, tapping, people often call it. It's the physical activity of getting the left and right parts of the brain to integrate to resolve and calm down alpha waves. Occupational therapy, I cannot talk about enough. Those folks are really good at understanding how the body is integrating their senses, and how to accommodate and change that. Not only for folks on the spectrum, occupational therapy is very big in aging services with people who've had strokes, etc. Play therapy, art therapy, music therapy, equine therapy, yoga. So all of these ways, all of these interventions help that parasympathetic nervous system calm down so the person can get in a state of calmness and be receptive maybe to cognitive therapies. Next slide. I'm conscious of the time. All of these are links, by the way. If you click on them, you'll get to where you want to go. These are all techniques that you can teach to people to do it themselves, including the bilateral stimulation, self-tapping. RAP is a self-advocates taught us a number of these. They told us that, here's our trigger worksheet so we can identify our own triggers and recognize them and plan how to respond to them. RAP is for people who are more cognitively developed, but it is empowering the person to, again, identify what they need to stay healthy. Dan Siegel's hand model of the brain, Google it. He has a model where he teaches very young children to understand what's going on in their brain so they can put the general in charge, as he says, and they can learn to do that. That's one whole area. The next slide. This one is, I'm not going to go over this. These are things based on direct communication. Sex education and counseling is a really big one with these folks, by the way. This is where behavior consultation comes in. But these are things that assume the person can communicate and have an exchange about what's going on. Next slide. Family-based treatments, I'm not going to go over these one by one, but there's a range of really good, effective ways of working with families and empowering families and coaching them and training them. The one at the bottom is co-regulation. When you click on that, you'll discover it's a methodology that was actually designed for direct care staff. And it's about how you yourself in the presence of someone who's agitated and overstimulated, how your behavior, your breathing, your voice tone can actually calm their parasympathetic nervous system. Really good thing for families in particular. Next slide. The last is, next slide. The really good news is brains are always growing, brains are plastic, they're developing, and these are kids. And school is a huge part of children's lives. We learned that during COVID, how detrimental it was for children not to physically go to school. And these kids get kicked out of school and kept out of school all the time. That's got to be remedied. They need the experience. They need the social contact. They need the rhythms and routines. They need the regularity of it. And so, as advocates, as family members, as direct care staff, we need to be working with schools. We've got an IEP and an ISP in common. We've got the concept of individualness. We've got the concept of self. We share the same values and the same goals, but working together is really, as I say here, non-negotiable. Next slide. And the other way is using outside of school Medicaid and Medicaid habilitation services to create opportunities for kids to learn things, to go to Boy Scouts, to use mental wellness programs, learn how to take the bus. I mean, all of these things are developing the brain, developing skills, developing competencies, developing self-confidence on a route to recovery. Next slide. So here it is, the paradigm in a nutshell. Make sure where they are and what they do, place that is safe, that works for them. I'll give you an example. I have a good friend. She has a son who's 32 years old. He has autism, significant characteristics, not has speech, but is very repetitive. Big, big, big guy. Works 4 days a week at the local grocery store. And when he comes home, every single night, he has a 2.5 hour bubble bath every night. And when he wants to go shopping, he buys bubble bath. And after a while, his mom says, God, is there something wrong with me? Am I neglectful? Nope, that's his place that is safe in the tub. Next slide. Who pays? Who's responsible? Child welfare, mental health, DD, education, juvenile are all paying for stuff. A place, an arrangement, therapies, education, they're all paying for stuff that fit in those three columns. It's a matter of constructing the services we're already paying for to be helpful to these kids. Next slide. What can the councils do? So these are my thoughts. You can banter this around yourself. One is to be teachers of both policy leaders, providers, who these kids are. What they're not kids in child welfare with mental health problems. They are kids with dysregulated behavior that comes from their neurodevelopmental disability, their trauma, their physical health conditions, mental health conditions. And by the way, if they're teenagers, it's complicating things. Teach people who the kids are. Let's get rid of the mystery. Complex kids is a big category. It's an adjective. It doesn't say anything. And teach policy leaders and providers that helping the child learn to self-regulate does require attention to all of their conditions, all of their conditions. Next slide. I think this is our last slide. This is where you start. When we interviewed all the states, they all said all kinds of different things, and they all had different things that they did. But one of the things they all said was eventually they had a kid that the governor said, fix this. I don't want to hear about this anymore. Or they had somebody say, I'm not paying $500,000 a year in that institution in Texas. Somebody said, you got to figure it out. And so the state agencies overcame their barriers, got on a call, and started talking about what are we going to do with this kid? And over time, they learned that that worked for a kid at a time. And then they started having calls, not about a child, but about how collectively they could do better. working organically from the ground up. So when people don't, if you start with, how am I going to create an integrated system of care? 5 years later, you're still talking about policies and procedures. You haven't gotten to a kid. So if you start with a kid, pretty soon, this child, if you say this child could really benefit from neurobiofeedback, whoa, where do we get that? Who pays for it? Why isn't EPSDT paying for it? And it starts leading to identifying the barriers so you can remove them. I think that's the end, Stacy? Yeah. So I think we wanted to give Beth an opportunity here, right? Yeah. So Beth, are you on and jump in?
Sure. Thank you so much, Nancy, for all of that overview. I just wanted to chime in and maybe just add a little bit about what councils can do. I know that I'm a little bit biased. I am Beth Stalvey. I'm the executive director at the Texas Council for Developmental Disabilities. And so, yes, I am biased, but I do think that councils do have a very unique and critical role in each of our states, very different than any of our other state agencies. We are charged with and also have the privilege of having resources that really can identify this who, what, and how that you've been talking about today. So who are the individuals with DD who tend to fall through the cracks in our system? And I think that we have definitely been talking about how they fall through these cracks. Councils can start conversations. We can fund projects to bring attention to specific populations and needs. And so I think it's really critical to understand these unique aspects so that we can have those conversations. Our projects also help articulate what the specific problem is in our state. So Texas Waivers and Services provide very different services than any other state. And so our council is really charged with understanding where the resources are. You mentioned all the payment strategies and funding sources. And so we have to do that specific for Texas because it's very different than any other state. So what is the specific gap? Is it our finances, our investments? Is it our culture? Is it our services? Is it provider expertise? Is it all of the above? So I think that one of the things that we've done as a council is really try to sustain messages. Like you've mentioned a few here, behavior is communication. Something just that simple really does shift the culture in having providers begin to interact with individuals in maybe a different way. And I also like what you said about remove the mystery. It can be sort of overwhelming if you've not had a little, or if you've not had past interaction. And so I think that we have a responsibility as councils to talk about that. Our projects also can create a pathway to improvement, really coming up with a specific model on how our state systems might be able to operate differently. And what I love the most about councils is that we can spend the time looking up the best practices and being able to share those. Our projects have the benefit of trying something new. If it doesn't work, we say, hey, whatever you do, don't try it this way because it didn't work. We learn the lessons up front. And then that way, when we are ready to scale programs, maybe it could be scaled faster, it could be scaled more efficiently. We can contribute to those conversations. On this specific topic of children with complex needs, the Texas DD Council awarded a project to an expert in our field, the Meadows Mental Health Policy Institute, who assessed these gaps. They spent a long time talking to providers, to families. They developed a model of support. And I believe in the chat, our grantee has been able to share some of the resources if you are interested. Our council role will be to work with the Meadows Mental Health Policy Institute to share these findings more broadly, to talk about where the gaps are, to work with our state DD providers, our policymakers, and others to really keep these conversations going and make sure that these children are getting the support that they need.
Can I ask a question? This is Scott Lindblom, stay in Alaska. I used to live in Arizona and stay in Alaska.
Hey, Scott, I think we're focusing on the current topic here.
What now?
I think we're focusing on the current topic here. Let's let them get through it.
Oh,
Are we on a point where we could do a question, Beth? Are you done?
well, I mean, I would ask
Yes.
a simple question because I've been on Department of Human Service with fundamental disability in the state of Nebraska have that program with behavioral health. Most states don't have that. So all these have a mental health DDD council that don't work with mental health. If you look at state of Nebraska with Health Human Service with fundamental disability, they work with behavioral health, same in Department of Human Service.
Scott, I'll just add, our state has some behavioral health committees, but they don't necessarily incorporate the IDD component as well as our DD
Well,
council would like.
that is
So,
against
yeah.
the health. That is against our 96 Constitution.
Great. Scott, thank you for bringing that up. And I think that's a good point. We're going to continue to work on this topic through NACDD. I appreciate you bringing that to the front. I think I just wanted to say, this is Mary again. I can't believe it. We had so much information. We're getting towards the end. I just wanted to make sure before we open up for a few questions. Beth, were you able to get through what you were going to talk about? Perfect. Okay, great. And Nancy and Stacy, we're done on this piece. Wonderful. Okay. So I guess we have some time for just a few questions. And then I also just wanted to offer that I'm also happy if people have questions they're not able to get answered in the short amount of time we have left. You're welcome to send them along to us, or I believe the speakers have added their information on the slides. And so when those go back, I'm sure Nancy and Stacy, if you'd be willing to continue to dialogue with people, is that open? Yeah, Stacy's shaking her head. Yes. Wonderful. So go ahead, Yolanda. I'll let you ask a question, and then no, if we don't get to you, our speakers do have their contact info out there. Great.
Yeah.
Yolanda?
Hello, I just want to say thank you. This was very informative. I will say one of the things, and I'm with the California Council, we have worked closely with behavioral health. And one of the things that I'm really focused on is working with crisis intervention teams and helping them understand the population. Specifically, everything that you guys were talking about is something that we are working with several crisis intervention teams, different law enforcement, and even currently with some new crisis intervention teams at the UC San Diego specifically. So thank you. That's all.
One of the things I would say, we're going to do Stacy and I are going to do a webinar with the Crisis Jam that goes
Oh
on.
yeah,
Yeah.
Crisis Jam. I love Crisis Jam.
And we've been thinking about how to talk about this because we are tending not to talk about a diagnosis because we have a history here of saying this is an issue of intellectual disabilities. It's way broader than that. And if you're a first responder in a mobile crisis unit, what you're looking at is somebody whose behavior is dysregulated, no
Yes.
matter what the diagnosis is. And so understanding the reason they're dysregulated has to do with how their brain is functioning and how hyped up they are in terms of fight or flight, and that the best you can do is co-regulation and calming. I think that's probably the approach we're going to take because I'm a first responder. Like I can't know every diagnosis in the world about everything. And but if I know if that behavior is out of control, that person doesn't have control and it's here and and they need time and space and interventions that calm them.
Yeah, and I that's why when you were talking about all of these things, it's basically what we speak about when we're talking to law enforcement and we're talking about crisis. And I've been on Crisis Jam before, so I love that.
That's great. And Yolanda, I'll also add, well, first of all, thanks so much for the work that you're doing because I do think that is a place that we can tap into an existing system that the mental health system, and I say it lovingly, but that we can infiltrate, right? And so I put a link to some resources that we have on the Link Center related to crisis prevention and response. And I will also say in the work that Nancy mentioned earlier that the Link Center has done with the 988 suicide and crisis lifeline system, we heard loud and clear that the number one thing that people feel ill-equipped to support if somebody with a cognitive disability would call that line is around communication. So what we have done, and you'll see that up there in the link, there is a specific resource called Communication in Times of Stress. It doesn't say anything about IDD. It doesn't say anything about brain injury. It says when you're stressed out, you're probably not at your communicative best. And so, to Nancy's point, what are some things that these call counselors can be thinking about and doing for everybody that will benefit the people that we're most passionate about serving and supporting, right? So, hopefully, you'll find some things up on the website there as well.
This is Mary. Can I add from the chat? Jolene is wondering, do you have any resources or know of any that come up in treatment approaches that help people with IDD process feelings and experiences related to disability?
Well, yeah, I used to be
Oh,
on Department of Human Service in state of Nebraska with Clarissa Larson, with Tyler Green, and Tony Green back 2007. And we do work with mental health IDD. All Department of Human Service is required. 1963, John, um,
thank,
John
thank you.
the mental health, 1963 and 1970, supposed to have mental health in fundamental disability council should work together as it is.
Thank you, Scott. That's great. If you have any of those resources that they're talking about, I'll put my email in the chat. Feel free to share them. And Nancy and Stacy, how about you guys?
Well, a couple things. Remember, body keeps the score, and that much of the um, that non-speaking interventions and supports can be very powerful, and people may be able to talk about their disability and use words to reflect on it, but feeling good about it and being with peers who can speak about it so they can hear. So they
Right.
maybe not be able to express it. But you know how, I don't know about you, but I love a lot of the comedians on TV because they say stuff I'm thinking, but I can't say out loud. I don't know how to do it. So one of the things peer support does is it articulates for you things you can't articulate. So I think self-advocacy groups, something the councils have been the only entities in the country that have stood by the way, are the self-advocacy groups.
Yeah, and not surprisingly, Nancy and I are on the same exact page because what I'm going to pop into the chat is, and actually they're called SARTAC. They're led by Green Mountain Self Advocates in Vermont, and they host a weekly gathering of self advocates and folks with lived experience where they talk about topics exactly like the one that you're talking about, Jolene. You know, how do I sort of process this and things like disclosure and all sorts of different topics, and it's all led by people with lived experience. And so it just might be some place to and just really
Yeah.
tap into.
So I also want to say this is the strength of the council. Self-advocacy groups that do not have a strong ally partner facilitator fall apart. And so having a person who is good at facilitating, helping people stay on topic, plan together, because self-advocacy still have collectively the executive function challenge. And so, what I've seen councils do is support allies of self-advocacy and fill in some gaps. And all the work you've all done supporting, you're the only ones that do it.
Nancy and Stacy and Beth, I just want to thank you guys so much for spending this time with us today. I can't believe how much time flies when you're having fun. I really hope we will go ahead and gather some of these great resources from the chat And again, as a reminder, we will send the PowerPoint and the recording out for folks who are wanting follow-up. And thank you all, everybody on the line, for staying with us for this great information. And hopefully we can continue this conversation. And again, please fill out the survey when you close out today. And
And we
have
are
a
here to
great
partner
day.
with you, anything you'd
We're
like
here
to
to
develop.
partner. I also threw in the chat, I just wanted to throw out there, People's First is one of those groups that's just underutilized and undersupported. And I think I've spoke within their group about mental health a lot, and I really appreciate what they do. So I'm throwing
Great.
that out there at the end. All right.
Wonderful.
Have a great night, everybody.
Bye.